You don't need to be sick to be harmed by a prescription drug. You only need to be uninformed. Some of the most serious risks in modern medicine do not come from rare diseases or experimental treatments. They come from prescriptions that feel routine. Familiar names, approved labels, quiet refills that happen month after month, often without a second conversation, without a reassessment, without anyone stopping to ask whether the original reason for the drug still exists. For millions of people, prescriptions begin during moments of vulnerability. A stressful year, an injury that will not heal fast enough, a surgery followed by lingering discomfort, anxiety that feels temporary, sleepless nights that start to pile up. In those moments, medication often feels like relief, stability, control. What rarely gets discussed is how often those short-term solutions quietly turn into long-term exposure. Not because anyone made a reckless decision, but because the system itself rewards continuation over reconsideration. Today, we are breaking down 8 prescription drug categories you should treat with extreme caution right now. Not because they are illegal, not because they never work, but because they sit at the center of the strongest warnings, dependency patterns, and safety failures in modern healthcare. This is not opinion. It is labeling history, regulatory alerts, and patterns that repeat across countries, clinics, and decades. If you are taking any of these, the goal is not panic. It is audit. Knowing what you are taking, why you are taking it, how long it was meant to be used, and what questions need to be asked before the next refill. We will go one by one. At the end, you will have a simple checklist you can use to audit any prescription you are given. Let's start with the first of 8. Number 1, benzodiazepines. These drugs are commonly prescribed for anxiety, panic attacks, muscle tension, and sleep. Names include alprazolam, clonazepam, diazepam, and lorazepam. For many patients, they enter the picture during a rough chapter in life, a job crisis, a loss, chronic stress, or sleepless nights that start to affect work, relationships, and mental clarity. At first, the relief feels immediate. Thoughts slow down. The body relaxes. Sleep finally comes. Because the effect is noticeable, the drug quickly earns trust. It feels like something that restores balance. But here is what actually happens. Safety labels warn about respiratory suppression and overdose, especially in higher-risk patients. That is why this entire drug class now carries updated boxed warnings that flag dependence and dangerous withdrawal. Benzodiazepines do not just reduce symptoms. Over time, they can retrain the nervous system itself. The brain adapts to their presence and begins to rely on them to maintain equilibrium. What once calmed anxiety now simply prevents withdrawal. The same dose that once worked well starts to feel weaker. Miss a dose, and symptoms do not just return. They rebound. Anxiety comes back sharper. Sleep becomes fragmented. The body reacts as if something essential has been removed. That rebound can include severe agitation, confusion, tremors, panic, and in some cases, seizures. Regulators updated boxed warnings for the entire class, emphasizing the risks of misuse, dependence, and dangerous withdrawal. The people most at risk are often the least warned. Long-term users who were never told the medication was meant to be temporary, older adults whose bodies metabolize these drugs more slowly, patients taking them daily for years without a clear exit plan, and anyone combining them with alcohol, opioids, or other sedating drugs. For many, the trap is not misuse, it is normalization. The medication becomes part of daily life, and stopping feels more frightening than continuing. So, if you are prescribed a benzodiazepine, the audit is critical. Is there a defined time limit? Is there a safe reduction plan if this ever needs to stop? Is there a lower risk alternative that could address the same problem? Because when there is no end date, short-term relief quietly becomes long-term dependence. For many patients, that shift happens without a clear moment of consent. That brings us to the second category, 2 out of 8, opioids. These are medications prescribed for pain, such as oxycodone, hydrocodone, morphine, and fentanyl, when used in controlled medical settings. They are often introduced after surgeries, injuries, dental procedures, or severe pain episodes, where relief feels urgent and non-negotiable. In the beginning, Opioids can feel like a lifeline. Pain eases, movement returns, sleep improves, daily tasks feel possible again. But here is what actually happens. Opioids do not just block pain signals. They slow breathing, alter reward circuits in the brain, and change how the body processes discomfort. Tolerance builds quickly. What worked last week often feels insufficient this week. As tolerance grows, doses creep upward. With each increase, the margin between therapeutic use and dangerous suppression of breathing narrows. Safety labels and regulatory guidance repeatedly emphasize the same risks: dependence, misuse, respiratory depression, and a dramatically increased danger when opioids are combined with other sedating substances. The highest risk scenarios are surprisingly common. Patients started on higher doses without tolerance, older adults with reduced respiratory reserve, people with sleep apnea, and patients combining opioids with alcohol, sleep medications, or anxiety drugs. For many, the original pain fades, the injury heals, but the medication remains. Pain becomes harder to quantify, and the drug becomes easier to justify. So, the questions matter. How long is this actually necessary? What early signs of breathing suppression should be recognized? Is there a non-opioid alternative, or a clearly defined tapering plan? Because the danger usually is not the first prescription. It is what happens after the original injury fades. And the next category shows how quickly that risk multiplies. It is what happens when the refill becomes automatic. Now we reach the third entry on this list, 3 out of 8. This is where the danger escalates fast. The combination of opioids and benzodiazepines. 2 common prescriptions, often written by different doctors, sometimes filled at different pharmacies, and frequently taken together without anyone stepping back to see the full picture. Each drug on its own carries risk. Together, those risks do not just add up, they multiply. Both suppress the central nervous system. Both slow breathing. Both deepen sedation. When combined, they dramatically increase the likelihood of fatal outcomes. This is not a theoretical concern. It is one of the most documented and warned against combinations in modern medicine. Regulators have issued explicit alerts advising avoidance whenever possible. Yet the combination still happens, not because of recklessness, but because care is fragmented. Specialists focus on their slice of the problem, and the whole picture gets missed. 2 legal prescriptions, often taken exactly as directed. This is where many people get caught without realizing it, often trusting each prescription because it came from a different appointment for a different reason. 1 potentially lethal pairing. The fourth category may surprise a lot of people. 4 out of 8. Antibiotics, specifically fluoroquinolones. Drugs like ciprofloxacin, levofloxacin, and moxifloxacin are often described as powerful, broad-spectrum antibiotics. They are frequently prescribed when infections feel stubborn, or when speed seems more important than precision. But here is where it gets disturbing. What happens next is the problem regulators specifically warned about. Over time, regulators have linked these drugs to serious and sometimes permanent side effects in certain patients. That includes an increased risk of tears or ruptures of the aorta, the body's main artery. Because of this risk, guidance recommends avoiding these antibiotics in people with known aneurysms or significant risk factors, unless no safer alternatives exist. Higher risk groups include older adults, people with high blood pressure, vascular disease, and certain genetic connective tissue conditions. For them, what looks like a routine antibiotic can carry disproportionate danger. In fast-paced clinical settings, those risk factors are not always fully explored. So, the audit questions are simple. Is there an alternative antibiotic for this infection? And do I fall into a higher risk vascular category? Sometimes the strongest antibiotic is not the safest choice, especially when speed is prioritized over fit. The fifth category is something most people don't even think of as dangerous. 5 out of 8. Non-steroidal anti-inflammatory drugs, often called NSAIDs. Ibuprofen, naproxen, diclofenac. These drugs feel familiar. They're often viewed as mild. Many people take them daily for joint pain, headaches, or chronic inflammation. But here's what actually happens. Regulatory warnings have strengthened over time, emphasizing that non-aspirin NSAIDs can increase the risk of heart attack and stroke. In some cases, that risk appears within the first weeks of use, and it grows with higher doses and longer duration. For people with cardiovascular disease, high blood pressure, kidney issues, or advanced age, this risk becomes especially relevant. What feels like minor pain relief can quietly contribute to serious, life-altering events. So, the audit matters. What is the lowest effective dose? How short can the duration be? And does my cardiovascular profile change the risk calculation? Because common doesn't mean low risk. This is where familiarity quietly lowers caution. The sixth category requires careful, respectful framing. 6 out of 8. Antipsychotic medications are used in older adults to treat dementia-related behavioral symptoms. Drugs like risperidone, olanzapine, quetiapine, and similar agents are sometimes prescribed when agitation, confusion, or distress becomes difficult to manage. For caregivers and clinicians under pressure, medication can feel like the only remaining option. But here is what the labels make clear. These medications carry warnings indicating an increased risk of death in elderly patients with dementia-related psychosis. This does not mean they are never appropriate, but it does mean the risk-benefit balance is fundamentally different in this population. The concern is not short-term sedation, it is long-term outcomes. So, the questions shift. Are non-drug approaches being tried first? What is the specific goal of treatment? And when will this decision be revisited? Because when a drug is used primarily to manage behavior, the risk can end up managing the patient. The seventh entry on this list is not a single drug. 7 out of 8. It is polypharmacy. The accumulation of multiple prescriptions, especially in older adults, is the core issue. The danger here is not one medication. It is how drugs interact, stack, and amplify each other's side effects over time. Falls, confusion, excessive sedation, bleeding, adverse reactions that do not show up until a tipping point is reached. Many medication lists grow not because each drug is still necessary, but because nothing is ever removed. Clinical criteria used worldwide identify medications and combinations that are often better avoided in older adults when safer alternatives exist. Yet, reviews are often rushed or skipped entirely. So, the audit becomes structural. Which medications are essential, which remained out of habit? Can anything be simplified safely under medical supervision? Sometimes the most dangerous prescription is not a pill, it is the pile. And the eighth and final category combines extreme effectiveness with extreme restrictions. 8 out of 8. Isotretinoin. Isotretinoin is a drug used for severe acne. For some patients, it can be life-changing, restoring confidence and quality of life after years of failed treatments. But here is what actually happens. This medication carries a severe risk of birth defects and pregnancy loss. Because of that, its use is tied to strict safety programs, monitoring requirements, and compliance rules that must be followed precisely. This is not casual prescribing. It is treatment with a built-in safety contract. Every step exists because the risk is real. So, the audit questions are mandatory. What are the exact safety requirements? What monitoring is required? And what does full compliance actually involve? Effectiveness does not cancel risk. It raises the stakes. At this point, an important question needs to be answered, and it's one that sits underneath every category we've covered so far. Why are these drugs still prescribed at all? And more importantly, why do they so often remain in place long after their original purpose has passed? Because risk does not mean banned. It means the wrong patient, the wrong dose, the wrong duration, or the wrong combination can turn a useful tool into a hazard. Many of these medications are essential in specific circumstances, in emergency settings, in acute phases, in cases where safer options have already failed. Used correctly, they can be life-saving or life-changing. Severe pain, acute infections, psychiatric crises, conditions that do not respond to safer options. The danger comes from casual prescribing, incomplete follow-up, and automatic refills that outlive their original purpose. Across every category, the same pattern appears, not because patients are careless, and not because doctors are malicious, but because modern healthcare is optimized for speed, not reflection, higher doses, longer use without reassessment, older age, sedating combinations, underlying medical conditions. That's where risk quietly multiplies. Not in dramatic moments, but in ordinary ones. A refill approved without discussion, a medication list copied forward year after year, a short appointment where no one has time to revisit old decisions. So, before we end, it's worth slowing down for a moment, because if there's one mistake people make, it's assuming risk only exists at the moment a drug is prescribed. In reality, most harm happens later, months after the original complaint, years after the initial diagnosis, long after the context that justified the prescription has changed. That's why this final audit matters. Here is a simple checklist you can apply to any prescription. Is this medication for days, weeks, or indefinite use? What is the most serious side effect I need to recognize early? What interactions should I avoid? Is there a lower risk alternative for my profile? When will this be reevaluated? If stopping becomes necessary, what is the safe plan? And what signs or tests should be monitored? Labels do not protect you. Marketing does not protect you. Informed questions do. Which one surprised you the most? And more importantly, which one made you think differently about something you or someone close to you might be taking right now? If you want another report like this, click the video on your screen.